Good morning, ladies and gentlemen. Welcome to this morning's special edition of Winning Against Cancer Public Symposium organized by the National University Cancer Institute, Singapore, also known as NCIS. My name is Annie, and I'm your MC for today. And before we start, please be informed that we have a photographer who is roaming around. He'll be taking photos of this event for use of NUHS and NCIS for public purpose in corporate materials, such as brochures, social media sites, as well as mass media. And a videographer has been engaged to record the presentation as well, which will be put up on the NCIS YouTube channel. So without further ado, let's start our program. I would like to introduce Dr. Huang Yiqing. She's a consultant medical oncologist at National University Cancer Institute, Singapore, and her main interest is in thoracic cancer. She's also an adjunct assistant professor at Yong Lu Lin School of Medicine, National University of Singapore. She is a recipient of the National Medical Research Council New Investigator Grant and the IASLC Academy Award in 2023. What's so special about her is that she's also the organizing chairperson for Lung Cancer Awareness Public Talk today. So without further ado, let's welcome Dr. Huang.
Thank you, Annie, for the very kind introduction. A very good morning to everyone. So today's talk is on lung cancer screening and treatment. And as you can see here on the right, Annie has already explained to us that we've got a series of events they'll be arranged from 10 o'clock to 4 p.m. And if you are free, please also join us for education sessions and some interactive activities for games and at a survivor zone at Suntec CT Atrium Tower 3 and 4. So without further ado, I think we'll start. Today's talk will comprise of 3 talks from 3 specialists. The first will be conducted by Dr. Mamta. She'll be giving us a talk and telling us whether we can actually prevent lung cancer, some of the risk factors, symptoms, and whether there's any role of screening in lung cancer. Secondly, we have Professor John Tam, who's the current head of Division of Thoracic Surgery, who will shed light on the advances of surgical treatment in lung cancer. And finally, I will end off with a talk on targeted therapy and immunotherapy in lung cancer. So let me introduce Dr. Mamta. She attended Guy's King's and St. Thomas Medical School in London and subsequently undertook postgraduate training in London and Cambridge. She has a PhD in lung cancer screening and specifically looks at the aspects of lung cancer risk. She's passionate about improving early detection as well as diagnostic pathways and outcomes for patients with lung cancer. The second speaker is Associate Professor John Tam. He wears many hats. He's also a mentor to many of us. He's the current head of thoracic surgery at National University Heart Centre. He's also an associate professor for surgery at National University of Singapore. He specializes in minimally invasive surgery using single port techniques. And he's also a champion for enhanced recovery protocols and opioid-free analgesias to maximize patients' comfort in their journey. So I think without further ado, let me invite Dr. Mamta, who will be giving us our first talk today.
Thank you very much for that kind introduction and for the invitation to speak today. So I'm going to talk a little bit about lung cancer in general, seeing as I have the privilege of being the first speaker this morning. So what is lung cancer? So you probably all know, but I'll say just on a very basic level, cancer is when abnormal cells develop and rapidly replicate, and they group. And of course, unfortunately, these cells can spread around the body as well. So they can spread via the immune system, and they can also spread via the bloodstream as well. And then they can spread to distant sites. Oh, thank you. Can you hear me? Yeah, okay. So they can spread to different sites around the body, which can be quite far away from the primary tumor itself. The diagnosis is usually made from CT scans, particularly in the case of lung cancer. It's the most useful type of imaging, but also from biopsies, so where we actually take a sample from the tumor and try to diagnose it based on how it looks under the microscope. So who's at risk of lung cancer? Somebody recently said, if you have lungs, you can have lung cancer. Unfortunately, this is true, but of course there are certain things that can make you at slightly higher risk compared to other people. So the biggest risk factor is indeed smoking and increasing age. Those are the two biggest factors worldwide. In certain parts of the world, particularly here in Asia, we do see that people have a stronger genetic predisposition, sometimes due to family history. And so therefore we even see quite a high rate of cancers, lung cancers, even in those who have not smoked. Other risk factors include things like asbestos, pollution, exposure to indoor cooking, and industrial exposures as well. So the symptoms of lung cancer, now unfortunately we often don't know about the symptoms until it's become more advanced in stage. But typically the symptoms that we might expect will be cough, phlegm, coughing up blood, symptoms such as tiredness, weight loss, or fatigue, and more specific symptoms which may be related to where exactly the tumor is in the body include things like hoarse voice, pain in the shoulder, the back, or in the chest itself, seizures if there's any evidence of spread to the brain itself, and of course breathlessness is something that we would expect with the lungs. The symptoms, as I mentioned, is definitely related to the stage. So as you can see here on the graph, let's see if the pointer works. Yeah. So, sorry, on this chart here, so stage 1 is when the tumor is relatively small and localized, so just focused in one part of the lung. And at this point, you may have absolutely no symptoms whatsoever. In fact, most likely you will not have symptoms. And typically people who are diagnosed at this stage is usually when it's picked up by chance, due to perhaps having imaging for another reason. As the cancer progresses through to the stages, and you can see stage 4 is when there may be multiple tumors either in the lung or outside the lung as well, there can be more symptoms. This just shows you some of the typical sites that lung cancer typically spreads to. So why is stage important? Well, the graph on the left here shows that we know that people do much, much better if they're diagnosed early. And that's a really, really important message. Stage 1 lung cancer can have a survival of 80% or even more. Unfortunately, stage 4 lung cancer can be much, much lower and can be somewhere between 10 and 20%. So it's really, really important, and this is at 1 year. So it's really important that we try to really maximize the survival by diagnosing lung cancer early. Of course, there are some people who are diagnosed at later stages that may be lucky to have a tumor that is responsive to some of the other treatments that are available today. And lung cancer has made huge advances in the past 10 years, and I'm sure we'll hear a bit more about that later on this morning. But my key message really here is to say that we really do need to try to focus on diagnosing lung cancer early for as many people as possible. And we know that currently, this is data from the UK, but this is very similar in most of the world, that most lung cancers are currently diagnosed at stage 3 or stage 4, where unfortunately we may not be able to offer curative treatment or what's thought to be curative treatment. So as I mentioned, the options for treatment vary by stage. The kind of gold standard, the ideal treatment that we like to try and offer people is, if we pick up early, is resection. That means surgical removal of part of the lung where the tumor is involved. And we hope that we can completely resect the tumor in order to achieve good outcomes for people. Of course, there's always still a chance of recurrence, and we have to do what we can to mitigate those risks as well. If it is a bit more advanced, there may be other treatment options that include things like chemotherapy, radiotherapy, and targeted treatments as well. Sometimes these can be quite non-toxic, not like how we normally think of in the terms of cancer treatment, and they can actually be even oral tablets, and sometimes very, very effective indeed. And again, I think we'll hear more later. So to talk a bit more about early detection. So I think the key message here is lung cancer is treatable, but of course if we detect it early, there's a higher chance of curative treatment. Unfortunately, there's no blood test at this point in time that we can reliably use to diagnose lung cancer. But of course, there's much, much research ongoing in this area, and hopefully in the future there will be. For the time being, the main tool that we have to diagnose lung cancer is a CT scan. And of course, CT scanning has also made lots of advances in recent years. The radiation dose has gone down, and this can be a really good tool. In fact, it picks up lung cancer in about 95% or even 97% of cases. So really, the number of cancers missed on a CT scan is very, very low indeed. So it's a really effective tool. But there are some possible harms, and we'll talk about that as well. So before I move on to CT screening in more detail, I'm going to just talk a bit about general screening. What is a viable screening program? So I think one of the first papers on this sort of topic was written by William and Jungner in 1968 for the World Health Organization. This table was just taken from a review paper that I wrote previously, but essentially, and you don't need to be able to read all the small text, but essentially it's just to go over what really constitutes a viable screening program. So just some of the points. It should be an important health problem. I think no one can argue that that's the case here. There should be an accepted treatment. The treatment should be acceptable to people. There should be a suitable test. There should be an early stage where we can pick up the condition and do something about it. The natural history of the disease should also be understood. And there should be an agreed policy on who should be screened and who should be treated. And of course, the cost of case finding should also be something that is balanced in relation to expenditure on medical care in general on a population level. So these are some of the factors. And of course, case finding is not a once and for all process. It's a regular thing that we would need to undertake year upon year for it to be effective. Okay, so how do we decide if lung cancer screening or any cancer screening is effective? Okay, I'm going to talk about something slightly technical. I hope I can take you along with me. So this is the case of a patient who doesn't have any screening test. Okay, they later develop symptoms of cancer in their life, and unfortunately, despite our best efforts, perhaps they pass away from the disease later on. If we have a screen involved in this program, then the cancer diagnosis is brought forward much earlier than when the patient would have otherwise developed symptoms. And let's say, for example, that despite our best efforts, we are unable to really change the trajectory, and unfortunately the patient still passes away at more or less the same time period, despite our efforts. In this case, it looks like survival has increased, but in fact, the time of death hasn't really changed, and we haven't really altered outcomes for this patient. In fact, we've probably burdened them with anxiety and distress for a longer period in their life where they've had to live with this diagnosis without actually benefiting the patient. Okay, so if that's the case, then screening is not effective. This gap in time, this increased time in survival, is known as lead time, and screening is definitely something that is subject to lead time bias, is what we call it. So we cannot use survival as a marker to determine if screening is effective. So what do we use instead? We need to know about lung cancer mortality. We need to know about whether or not we can actually improve outcomes and reduce the number of people dying from the disease. And in 2011, this was a paper published from the United States, had over 50,000 patients, participants, and they showed that we can reduce lung cancer mortality by 20% if we expose people to lung cancer screening. This was an annual screen for 3 years. Okay. Unfortunately, although there was a lot of excitement about lung cancer screening after this study, it hasn't really taken off globally until much, much more recently. And then in 2020, there was a second study. So I think a lot of the lung cancer screening community was waiting for corroborative evidence that what we had seen was actually true. And there are a fair amount of skeptics as well. And this was a European study that also showed quite a significant impact. It was a study that was mostly done in men. And so the numbers you see there for men are sort of a tighter band of showing that the benefit is more certain. The band of benefit for women is higher. Don't worry too much, but essentially this 0.61 suggests that women may benefit up to 40% lung cancer reduction in mortality, relative reduction, which again is a huge amount. It signals that perhaps women may benefit more from screening than even men. And this is something that's quite pertinent in Asia, and we'll come on to that as well. This is just some basic data that doesn't look at lung cancer mortality, but is another marker of improved outcomes from lung cancer screening. And this is just taken from a pilot study that was part of my PhD. And we showed that instead of having a very high rate of stage 4 diagnosis, as shown by the kind of purplish bars on the left-hand side, we actually reversed the graph completely, showing that the stage 1 diagnosis went up to that level. So we caused what we call a stage shift, that we had much higher rate of diagnosis of stage 1. And we were able to translate that into treatment outcomes as well, in terms of resection and chemotherapy, radiotherapy, and other radical treatments. So it's even achievable in the real world, because this was not really a clinical trial in that setting, but it was a real world study. And many other real world studies have also shown the same thing. So the harms of screening. I'm going to talk about some of these in a bit more detail. The ones I haven't got a slide for include false positives. So a false positive is when we do a test, we think we found something positive, we think we found a lung cancer, for example, on the CT scan, but of course later on the investigation subsequently show that it's not a lung cancer. So of course that causes unnecessary tests, investigations, exposes people to the harms of the tests potentially, or treatments, and turns out to be benign. So we of course want to minimize how many of these we have. Similarly, false negatives. This is when we miss there is a cancer on a scan, for example. I did mention that the rate of missing this on a CT scan is very low indeed, and so is less of a concern. But again, it's something we have to make sure that if we ever do screening, we minimize the risk of false negatives as well. The other three I'm going to talk about in a bit more detail. So pulmonary nodules. What are pulmonary nodules? These are basically what I tend to tell my patients are like a white spot on your lung. It can be anything in size from 2 millimeters up to 30 millimeters. That's 3 centimeters in size. And we see them very commonly. So this graph is from the data from the American study that I showed you, and they screened rather a lot of people, and they picked up rather a lot of these pulmonary nodules. In fact, 1/4 of people have pulmonary nodules, and that's in the US study. It may be, we don't know what the rates are in Asia, it may be even higher because of rates of things like TB, tuberculosis, and other things that can also affect this. So it's not really a false positive, although some studies have called nodules false positives, but actually we know that the majority of these are not cancerous, they're not malignant. So we can sort of treat them as indeterminate rather than being malignant as such. But of course, nevertheless, it does generate more tests, CT scans, and potentially cause anxiety and worry as well. And actually, only a very small proportion of these people go on to develop cancer. So in the NLST, it was about 25% with nodules and 2 with cancers, in that out of 100. Now, in our real-world study that I'm going to just show you, we were able to improve outcomes a little bit. So here we reduced the number of nodules by changing how we interpreted the CT scans, and this is really, really key, how we read the scans, what we regard as positive, what we regard as needing follow-up, and of course, who we screen. So in this particular study, we screened very high-risk people, and we picked up more cancers. Oh, yes. Yes, so that's just the acronym, sure, that's the acronym for the study that was part of my PhD project. It stands for Lung Screen Uptake Trial. And because the main research question in that trial was about how to engage people from lower socioeconomically backgrounds, and so it was about uptake and engagement. But of course, by trying to uptake and engage people into lung cancer screening, we were able to screen about 1,000 patients, and so this is data from that.
So it's not local data?
This is local data from a study in London when I was working there.
Local data, which is Singaporean?
No, not Singaporean. But this is data in smokers. And of a certain age, so we're very high risk. I'm going to come on to how this is relevant to Asia in a moment. Yeah.
Thank you.
Thank you. So I'm just talking still very generally about the risks of screening. So radiation, I think, again, is something to be aware of. A normal diagnostic CT scan has what we call 6 millisieverts of radiation. A low-dose CT scan is fantastic. It's really, really reduced the amount of radiation. But of course, it's still not nothing. And again, it's something that we just need to consider and make sure we try to minimize in the way that we manage screening and the consequences from screening. It is about 100 times that of a normal chest X-ray. Okay. And overdiagnosis. So what is overdiagnosis? It's something that's probably got a lot of media attention, especially in breast cancer screening recently, over the past few years. It's when you have a cancer that is very slow growing. So in this picture, for example, this is a very small nodule, 3 millimeters. It grows to about 6 millimeters over the course of about 6 years. It's still probably not going to cause any symptoms to this patient. It's a very early stage 1. And of course, if this patient is, has other medical problems, etc., they may end up finding that they somehow die of something else in their lifetime and never even really know that they have lung cancer. So what we really want to do with screening is find the people not who are dying with it and have no symptoms from it, but the ones who are going to suffer harms and get benefit from it. Okay. And so just to demonstrate that a bit more. So in effective screening, you have the onset of a cancer, then you have cancer symptoms, and then you have where you would have had otherwise lung cancer death. We can interject by having screening, and we can hopefully cancel out the fact that this patient ever gets symptoms or ever dies from it. And they hopefully go on to live a long life and die from something else. In overdiagnosis, unfortunately, this doesn't happen. The cancer is detected, but they may die from something else unrelated, and in which case the symptoms and the death never have a chance to manifest. And actually, by screening this patient, we haven't done anything good. Now, the rates of overdiagnosis in lung cancer screening are probably relatively low, particularly in relation to other cancers. So it's something that I don't want to overstate, but it's still something that, again, people should be aware of. We know that we can probably minimize the risk of overdiagnosis by, again, how we select people and how we manage the lung nodules. And then just a bit of data from a qualitative study, again, I did in my PhD. Actually, does overdiagnosis matter? You know, actually, if you are faced with the possibility of having a lung cancer, many people will feel that I just want to have it out. I would rather be free of my cancer, and I'm less worried about overdiagnosis. And again, I think that's something that we need to be very, very mindful about, and this is where things like qualitative data from people who have gone through the condition or who are at risk of the condition is very, very important. And similarly about radiation, it's very hard to know how many CT scans can cause damage in the long term. Of course, we need to minimize how many scans we do, but we do need to balance that with the benefits we can get from screening. Okay, so I think this slide is really just to demonstrate that although there are harms, we do need to see how they are valued and perceived by the public and what really matters to people and to patients. A very quick slide on equity and uptake. I mentioned that my study was in lung cancer screening for people from more socioeconomically deprived backgrounds, and we know that lung cancer can more disproportionately affect people from those kinds of backgrounds, and it's really important to make sure that if we offer screening, it's done in such a way that everyone is able to have access to it. And really that means that we sometimes have to give a bigger stool to those who need a bit more help in order to be able to get the same benefits as other people who may have access. This data on the right just shows that the risk of lung cancer increases with deprivation. This is a graph taken from a large study in the US, but essentially what I'm trying to say here is that the more often we screen people, whether we screen them every year, whether we start from a very young age and we finish at a very late age, and we loosen our risk criteria, the more we screen, the more cancers we will find. So of course it can be beneficial, but of course we have to weigh that with the potential harms that I've talked about. So finding the optimum screening strategy is really, really key. How often we should do it and who we should offer it to. Again, if we focus on those at the highest risk, we can really minimize, or rather maximize the benefits and minimize the harms. Okay, but so who is at risk? So I'm just going to talk briefly. We talked earlier about who was at risk at the very beginning of the talk, and I mentioned about things like age and smoking history, and of course family history is important as well, particularly here in Asia. So in globally, US was leading. So for about a decade, they've been offering lung cancer screening, predominantly to smokers of a certain age. In China, so in China, they're now offering screening as well. It's supposed to be a national program, but of course, it is being offered to predominantly to smokers, but I think they're also offering it to non-smokers as well. In the UK, it's just been approved to have a national screening program, but it's not yet underway. And I think in Korea as well. But Korea, again, also focusing on smokers and ex-smokers of a certain age. There are a number of smaller projects, typically academic studies and small-scale projects where they're screening in Europe and in other parts of the world, including many places in Asia, and including Singapore as well, where the Solstice study has been recently launched in lung cancer screening, so people can enroll into this now. Okay. And the key thing that I want to mention is that in Taiwan, which is one of the really leading centers for lung cancer screening in Asia, they've done a massive study where they've offered screening to people who have an additional risk factor, a certain age plus an additional risk factor, whether that be smoking or family history. And they've actually shown, they've just published their data and shown that they have quite a high pickup rate of lung cancer. So in Asia, I think the way the direction of travel is going to be that we focus on people with any additional risk factors. And exactly how we define that is something that can be discussed and worked out, particularly in Singapore. But certainly family history seems to be a strong indicator and could be one of the factors. So what can we do now? And we can stop smoking. So anyone we know, we should of course encourage them to stop smoking. We respond promptly to symptoms. Lung nodule surveillance. If you have a white spot on your lung, particularly those above 5 millimeters or 6 millimeters in size, those are the ones that we really need to be monitoring. The ones that are smaller, it's technically we don't need to follow up according to the worldwide guidelines. And again, that's something that we can be doing more research on in the Asian context. Screening is part of academic studies, as I mentioned, and of course, the excellent options for treatment in terms of drugs, chemotherapy, targeted treatments, novel treatments in terms of radiation and surgery, which I'm sure we're going to hear more about shortly as well, and which have really advanced a lot in the past 10 years. What we can expect in the future, lung cancer screening, I think it's going to come. In some shape or form, it has to come because it's one of the best, strongest tools we have to really improve outcomes for people with lung cancer. Exactly how we do it is something that we need to finalize. A blood test or a breath test to see who is at risk. Hopefully, one of these things can also help. Then we can potentially offer screening to a much bigger group of people and then offer the scan part, the bit that carries the harms, to a smaller group. That's what I would dream and hope for. Artificial intelligence, of course, is going to be part of it, learning more about genetics and the behavior of lung cancer in different groups. And of course, maybe even including things like cardiovascular screening as part of lung cancer screening and continued more proactive approaches for the early detection of lung cancer. Of course, we always ask people to support all the research so that we can learn more and improve what we do. So I'm just going to finish my last slide. This is a case study of a real patient who I saw recently, Mr. X, age 69, who never smoked. His father had lung cancer. He was fit and active until recently, and he had a history of chest pain and increasing shortness of breath. Unfortunately, when he presented, he had fluid on his lung and showed a tumor on the right lung. And the further investigations revealed that the cancer had spread to the bone, adrenal glands, and to the pleura, which is the lining around the lung. The treatment was unfortunately to control rather than cure the disease. Now, thankfully, he's had quite a good response with the drug that he's been put on, but it just highlights that had this patient had screening, we could have picked it up earlier, we could have resected it, and he could have been cured. Okay, so I want to leave everyone with a very positive message that yes, there's something we can do. We need to be mindful of the harms so that we do it properly and efficiently and with minimizing the harms. But of course, it's a really positive step in lung cancer. Thank you very much for your kind attention. I'll be happy to take questions later.
Thank you, Dr. Mamta. Let's welcome our second speaker of this morning, Associate Professor John Tam. Professor Tam will speak about surgical advancement in the management of lung cancer. Let's welcome Professor Tam.
Good morning, everyone. You can hear me? Well, welcome and thank you for spending a Saturday morning with us. So I'm here to share a bit about surgical management and the advances that we have. So it's of no doubt that lung cancer is a problem. It's kind of like an invisible problem to many of us. We are happy not to know about it. But I think in many Asian countries, it is quite common. And many people would know of someone that had suffered from lung cancer. And so is Singapore, in fact. Singapore is not immune. So this is the latest data we have by the government. They collect data every 4 or 5 years. And so this is up to 2019 is the data we have. And over a 4 to 5 year period, you can see there's about 8,000 new cases and a lot of deaths. So only about 2,000 plus people out of that 5 years get cured. So that translates, if you do the math, to about 16 people dying from lung cancer every day, pretty much. And that's a lot. And that's a lot of families, there's a lot of patients that are suffering from this disease. So how can we do better? I think it's easy to be concerned, it's easy to be scared, it's easy to be worried. But I think, like Dr. Mamta say, what we want you to hear is a message of hope that there's a lot being done. We're not there yet, maybe perhaps we will never be there because we're always trying to do better. But there's a lot of advancements, and we can, hopefully together, do better for our patients. So, you know, lung cancer used to be think of a smoker's disease, old man's disease. In fact, when I was back in the days when I first got into the field 25 years ago, it's like, you know, you smoke all your life, you deserve it. I mean, this is an invisible, this is a hidden message, right? You know, nobody cares. It's the poor man's disease. You smoke all your life, you're a laborer, you know, what are you complaining about? You get cancer because you smoke. No, but it's no longer the case. No longer the case because, first of all, we don't blame the victim. It's not the people's fault that they're, you know, we're all suffering from something. I think, you know, diabetes or hyperpressure. It's not the person's fault. It's just part of life. And secondly, there's a lot of changes. You know, instead of being an old man's disease, it's still an old man's disease. Most of my patients are 60s, 70s, and even 80s. But it is shifting towards the left, as in they're more and more common. We see people in the 40s and the 50s, some even in the 30s, and you know, some even in the 18-year-old and already had cancer that spread. You know why? We are not quite sure. It's not like very, very common. It's very, very rare. But it does happen when it doesn't happen so much in the past. So in fact, half of my patients that we found lung cancer in my practice, probably not in some other doctor's practice or some other cancer doctor's practice, but in my practice, half of the patients that come to see me have cancer, and I'm predominantly doing cancer. They have never smoked in their life. So it is no longer a smoker's cancer. And in fact, this the book on the left is on the New York Times popular seller list for like a decade. It's still selling in some of the major bookstores. But basically, he was a doctor himself. He was a brain surgeon, and he was in training. And all of a sudden, and he lives, never smokes and all that. And then, but of course, he's like lacking sleep and not eating properly and all this. But he wake up one day and he found pain in the bone, and then he found that actually he had lung cancer that spread. And so this is a book that he wrote, detailing that how he go for treatment, how he got married, his daughter is growing up, but then his cancer treatment failed actually. So the last chapter was finished by his wife. A very good book. And it basically brings home the fact that nobody's immune, even the doctors themselves. And this picture on the right is someone in Singapore that has suffered from lung cancer, never smoked also, and died from it. A young person, never smoked. This is one of my patients. He was featured in the newspaper, and he was being interviewed for why he was a very fit person. I got his permission to share his photo, obviously. He's a very fit person, and the question is why he got lung cancer. So I think Dr. Mamta had bring out a few possibilities, but for people that not smoke, I mean, pollution, air, we cannot not breathe, right? If we're not breathe, we're not alive. So, you know, maybe something in the air, but then, wow, panic, right? You know, like, how, you know? But air pollution is real, and I think we have to, that's why all the green efforts, right? Greening the world, preserving the earth, all these are very important efforts. Perhaps, you know, all the air that we are breathing in, we can keep as clean as possible. You know, a lot of us cook, not me, I wish, but when we cook, we can also ensure good ventilation, airflow, to make sure that we're not breathing in all these fumes that are potentially containing something not good for the body, right? Because the lung has many important functions, and one of it is being a filter. So the lung is a filter where it actually, the air, the contaminants in the air would get filtered through. But if it's very, very fine particles, what you call ultra-fine particles, then perhaps the lung cannot filter through, and it would go straight into it would sit in the lung, or maybe it would go through the body and create problems for the body. So we talk about, in any cancer, we like to talk about the top 10 symptoms and all this, but when it's very, very early, actually there's no symptoms. Most of my patients have no symptoms, especially when most of my patients are early cancer. But even when some patients, we diagnose them with metastatic cancer, and they say, hey, how come, doctor, you say I have cancer here and there, based on the studies, but I feel so fine, I feel so good, I have no symptoms, so that's how it is. So I think that doesn't help you per se that, okay, you get no symptoms. So I think if you do have symptoms, I think don't ignore it. So, but how, right? I mean, all of us can occasionally have a cough here and there, right? So I think I will usually advise that if you have a new cough, like something that's new, not you've coughed for 10 years and it's been the same, right? But if you have no cough before and all of a sudden you start coughing for 1 month, 2 months, okay, give it some time, right? Give it some time, maybe you have just have a flu or something. But if you've coughed for 3 months and it still hasn't stopped, maybe you should see a specialist or see a GP first, and then maybe you should get some investigations done. And to find out whether it is something important, right? I mean, this is a scan from a lady. I treated her in 2008, and this is her heart. This is a cross-section of the body where the top is the front, the bottom is the back, this the left side, is the right side. So that's the heart. The back is the lung, and she has a big tumor hiding behind the heart. X-rays cannot find this. She has no symptoms. Well, actually, she has been coughing up blood for 3 months. Some blood, not a lot of blood. But she has never smoked, and she's got a big tumor. This is more commonly what we used to see 20 plus years ago. Okay? But cancer has changed, and everything has changed, actually. So for a while, 10 plus years ago, 10, 15 years ago, we are more common to see something like this. And this is a cancer because it looks like not normal, right? I mean, normal lung looks like this. And this is obviously not normal. What I call angry looking, it's like, pushing boundaries, So it's obviously not normal. And this is more commonly what we see for a long, long time. And nowadays, more and more commonly, because of all the advancements, scans are done for many reasons, like to test the heart, to test the thyroid, to test the liver, test the kidney. And then something get picked up. Something get picked up that are very, very small, not like the one that I showed you just now, not like this, certainly. And is it cancer or is it not? So that becomes a problem. So like this scan comes from a 55-year-old non-smoker, never smoked, tiny little dot here, 4 mm, and the person wants it removed, and it turned out to be already a very early cancer. So when we can pick something up like this, the cure rate is very, very high. Let's say if we pick something up that's less than 5 cm, or less than 5 mm, or less than 1 cm, you can almost kind of tell the patient that you don't have to worry. Chances are you'll be cured, because every step of the way as the cancer grows, you can see the survival comes down. So if you can pick it up when the cancer is very, very small, the survival is very, very high. It's very, very good. In fact, anything that is stage 1, which is less than 3 cm, that hasn't spread, is 80% and above. So if you have like a 5 mm, half a cm, your survival can be very, very high. So the key then is how to pick it up and how to differentiate it. The challenge, nothing is easy. The challenge is some may grow, like this one was being followed for 3.5 years, and you can see that it's growing bigger and it's becoming more solid along the way, whereas this one was followed for 6 years and it never changed. So it's not like so straightforward that, oh, you see something not normal, let's go to remove it or do something about it. It's not something so straightforward all the time, which is why Dr. Mantha just now was trying to bring some distinction to that. Here's another example where it was being followed, and you can see something that doesn't look very bad at all. It's just a little haziness can become like cancer. So I'm going to shift to focus a little bit more about the lung, the surgery. So a lung is a beautiful organ. It is just like any structure in the body. It's got roadmaps and boundaries and areas to it. So we actually have 5 lobes of lung in the body. Lobes are like a city, so there's 2 on the left and 3 on the right. But each of these lobes have different segments to it, different towns within the city, so to speak. So of course, if we have cancer, then it used to be that standard is to remove a lobe. That's one of 5 lobes, which is about 20% or so, depends on which lobe. So that's the standard operation for a good 1999 to maybe 2005, or sorry, 2015. So a good close to 20 years. That's the operation that we do as the standard. But in the last 5 years or so, we know that if we don't have to remove so much lung, especially nowadays, we're finding cancers smaller and smaller, earlier and earlier. So maybe we don't have to remove the lobe. Maybe we can remove smaller than the lobe. Maybe you can remove just a segment itself, and it's just as good. So in the last 3 years or so, 3 to 5 years, we've been starting to do this about 5 years ago, and the evidence really started to come in very, very strong in the last couple of years. So we know that if we don't have to take out the lobe, we can take out less than a lobe. We can take out a segment, and in some case, we can take out even less than a segment. So there are many different types of surgery. You know, as I mentioned, lobectomy here is the standard operation for a good 20 years or so. Sometimes when tumors are very, very big, we have to even remove a whole lung. I have a few people in Singapore walking around. They're living their life, traveling around more than me, even though they just have one lung. It's possible. And nowadays, more and more common, if possible, we do take out a segment, which is like a smaller, about 5% of the lung instead of 20% of the lung. You know, it's one segment. So, and sometimes we can even take out even less, what we call wedge resection. Just a little bit of lung is taken out, maybe about 3% of the lung. So this is the patient that you saw in the newspaper earlier. He's young, he's fit, he exercised all the time. He was about 45 or 50 at that time. And he was already had 2 proven cancers, plus something that's very, very small that was precancerous, or going to become cancer. Adenocarcinoma in situ is called. So instead of removing 2 lobes, which is close to 40% of his lung, we actually just managed to take out 2 segments. So that's about 10% of his lung. So a segment here, and we save 90% of his lung. So he's still, he within a very short time, he go back to his exercise routine, and he has got no pain and all that. I'll tell you how we do our surgery in a moment. So he was very happy that, and you can see that this is before the surgery and this after surgery. And you can see why X-rays are not very useful, because X-rays, there are a lot of normal structures on X-ray, which kind of the cancer can hide there also. So if we look back, correlate the X-ray with the CT, that's where the arrows are showing the cancer. But you can see that there are all these other normal structures that can also look similar. So basically, he had a lot, like you can hardly tell that I've done 2 surgeries, one on each side, on the before and after picture. So here's another patient of mine. She is very young, obviously, never smoked. She had a very indolent, slow-growing type of cancer. So she actually had a tumor right here in the middle of the left lung. And she saw many doctors, many hospitals. They all say that she had to remove the whole left lung. We managed to take out, again, 2 segments, one in the upper lobe, one in the lower lobe. So it's about 10% of the lung instead of the 50% of the lung. And you can see this is before. Again, very hard to tell that there's something abnormal there, because it's just kind of very close to normal. So that's where the tumor is. And after the surgery, the whole lung is still look like it was there, other than less than 10% missing, and she's been fine ever since. We've been seeing her. We've been seeing her now about every 2 years or so. This is, I think, 2015, something like that. This many years ago now, this patient. So we have been trying to do better and better for our patients all the time. All the time, that's our commitment, is to try to do our best and try to do better and better. So when I was, back in the olden days, when I was in training like 25 years ago, lung cancer surgery was known amongst the surgeons as the most painful operation. It's no longer the case. We are the least painful operation. You know, we have moved a long, long way. So how do we get there? Why is chest surgery so painful? Because there are a lot of structures there. First of all, there's the bone, there's the ribs. You know, the rib is called a rib cage, right? So the rib cage basically kind of caged the lung inside. So if you want to get access, in the olden days with the, you know, chances are that some ribs might be broken, which can hurt a lot. there are also a lot of muscles. And the muscles are not just there sitting there, right? The muscles are important for two things. Number one is breathing, right? The muscles help you to breathe. Number two is when you move your arms, your shoulder, all the muscles there are useful for that. So if the muscles are disturbed or cut, that would have caused discomfort to the patient. There are also many nerves. All the yellow things that here you see are nerves. So when the nerves are basically disturbed in a certain way, then they give signals. They give a numbness signal, a comfortable signal, achy signal. So in the past, we have to make big cuts, and that's why it was not a comfortable operation. You know, it was easy for the surgeon, but not easy for the patient. The patient needs 3 months to recover. So for many, many years now, actually, in fact, since 2009, in NUH, we have standard offered this operation to all our patients. You know, most of our patients have this surgery, 90% or more, except if bigger tumors, very big tumors, then we have to make the cut a bit bigger. But now we do single port surgery, me and my team. So this is the standard type of cut. It's slightly bigger than 1 inch, and we have special instruments where we put through that small cut. So we did as I mentioned, we did our first operation in 2009. That was ages ago. So it's a proven technique, time-tested, very, very good for patients. In fact, this was a medical student. The first case was in a medical student. He asked for it. I was doing 2-port at the time, and it was successful. So we rolled it out for all the patients ever since, and it's been very, very good. And you can see we actually avoid all the muscles. So we don't cut the muscle. We go between the muscles. We don't break any ribs, and we are very, very kind to the nerves. So all our instruments are like chopstick, like thin chopstick, 5 mm or less. So there's a scope where we see through, and everything is magnified on the screen. So with that technology, we can see everything very well. And these are all our instruments. Oh, sorry. These are all our instruments that are all like chopstick-like instruments. And we protect the wound with a very soft, elastic plastic protector to protect the wound. So we're very gentle about that, about the wound, and this is me operating, doing the surgery. So we have rolled this out for most of our patients, and most of the surgeries are done like this, and we've published in international journals to show our data. And it's not just about the surgery. In fact, it's the whole process, the whole chain from before surgery to during the surgery to after the surgery and the aftercare. So we have what we call an enhanced recovery protocol that you can see. This is the complexity of it. It's many, many things that we do, you know, along the whole chain of events to try to help patients recover well and recover faster and better. So in fact, in our pain score, this is our pain score that every shift, the nurses would come and show you, ask you, you know, out of a scale of 10, how much pain do you have? It's from 0 to 10. So these are all data that the nurses collect, and it's documented. So in the first day, the patient's pain score is only 0.3, not 10, out of 10, you know. So it's not even 1, it's 0.3. And then by day 5, it comes down to 0. Now, I can give, any person can have a pain score of 0 if I give you enough pain medicine. But most of our patients are only on Panadol, okay? And some are on some mild medicine like gabapentin, which is a nerve stabilizer. None of, all the patients, 99% of the patients do not need something that is stronger, like morphine type of medicine, which is creates side effects and all that. So most of our patients require just like Panadol. So it becomes a very good surgery for the patient. And this, in fact, this picture was on Straits Times a long time ago, but she was 88 years old when she go for surgery. If she's still alive, she's 95 plus already. This is a long time ago. This is a middle-aged man, and he was a doctor from another country, and he was discharged on day 2, and this picture was taken on day 3 after the surgery. So you can see he was looking very, very good. So I like this picture because it illustrates how good. And this email is written by another patient of mine, and he basically said that, you know, he didn't have any pain, and 1 week after the surgery, he was able to go to a family wedding after that. So this evidence that most of our patients do not suffer from the operation. And we have in NUH built a team. We have about a 20-people team that look after the lung cancer patients for after lung surgery. So it's not just about the one person. It's not just about the surgeon or the doctor. It's about the whole team trying to come in to help the patient. So I think I'll show a quick video after this. I think this time. But basically, lung cancer can happen to everyone, smokers and non-smokers alike, and it has the tendency of becoming a younger cancer. Early detection is very important. I think there are efforts made in Singapore and Asia and in the region towards that. But sometimes there may not be any symptoms at all, and if people do have symptoms, they should seek attention not too long after, maybe about 3 months or so, they should go and make sure that everything is fine. X-rays are not very helpful, but CD4X are known to help. And we are now routinely doing single-port lung surgery for our patients, which have minimal discomfort and fast recovery. And we endeavor to save lung whenever possible so that the person can go back to their normal lives and breathe normally and basically get better as fast as possible. So if we can show the video now. So this video is a bit dated. It's a couple of years ago. We don't have a new one yet, but nothing has. We've only gotten better from then. So and these are not like highly selected patients. These are routine type of patients that are. In fact, all of them are non-smokers that are shown in this video. So yeah. Except for one. One was a smoker.
Felt that my neck and my shoulder have this extreme pain. To a certain extent, actually, it does give me these breathless feelings. So I visited a respiratory specialist. They did an X-ray on me, and they discovered a nodule on my left lung. So I did a CT scan. They discovered that the nodule is present on my left, as well as nodules present on my right as well.
So when I went to the polyclinic, the doctor took X-ray, and then they noticed some non-regularity of the X-ray result, so that was why they were giving me a lot of antibiotics. But after 3 sets of antibiotics and X-ray, they realized that the irregularity on the X-ray does not go away.
Personally, I'm actually exercise quite a lot. I don't really drink, don't smoke. My family have no history at all. So the first question come across my mind is, why me? I did all the right things in life, and why me?
If I'm not a high-risk person that will cause lung cancer, do I really need to go through this process?
The moment that they told me that they have to cut away my lung, I become very panicked. What next? Can I still jog? Can I still run? Can I still breathe? So all these questions start to float up, but at the same time, I know that I shouldn't be waiting for too long. From the day that I went to Prof sessions, the very first sessions, that he spent quite a long time explaining to me about what's happening. I would not say just only a medical care, but also the psychological care part of it is that how you guide the patients and give them the full comfort along the way.
They did a pre-assessment whether I was suitable for surgery or not. This is a precautionary measure, and the team discussed. The anesthetist also checked on me, all the standard checks, and from there we proceeded.
Advances have made so much that the open type of surgery can be avoided. So a slit actually could be made on the side of the rib cage.
He did this, he devised this single port surgery where the camera, cutter, everything goes into one hole and just snip and remove it. So no bones cut. When I was awake, I was surprised that my chest is still intact, not sawn. And I could only feel the little bit of plaster at the side.
So all in all, my stay with the hospital was only about 3 days, including the day that it was spent in high dependency and in the operating theatre.
Life can actually get back to what we are doing in the past before surgery. So it is actually very much more of what you call us trying to actually overcome our own fear, which some of them could be unfounded.
So you don't need anyone like me No need anyone to bring me in, no need anyone to bring me out. Just like that, as simple as that. For me, I'm very lucky, 2011, now 2016. I'm still happy.
I have done my right 3 months ago. I have just decided last 2 weeks to do my left, and I just have my left lungs operated on about 1 week ago. And I'm sitting down here talking to you, smiling at you. And in fact, 3 days after my discharge, I just did my 3.5 kms morning walks again. So I'm perfectly okay. I'm still all right. No problems about it.
The thoracic surgery team worked together in order to give the patient the best experience during the hospital stay. We minimize the cuts to make it as small as possible, and by doing so, the patient will have much less pain and they can recover much faster. They can breathe well and cough well, and they can move about and mobilize well so that they can return to their normal lives as soon as possible.
So thank you very much. I'll address your questions later. Next, we'll invite Dr. Huang, who will share with you the advances in medical treatment in lung cancer. Thank you.
Thank you. That was a very inspiring talk by Professor John Tam. So I'll load my slides. Maybe just a show of hands, how many patients, how many of you here have relatives or friends who have passed away from lung cancer? Right. Thank you. Yeah. All right. So today's talk is on target therapy and immunotherapy for lung cancer. These are, I think, two of the most important breakthrough treatments that we have had in the last 2 decades. Okay, in the next 20 minutes, we'll be talking about how common is lung cancer in Singapore, and we'll also evaluate the role of immunotherapy as well as targeted therapy. We'll discuss how they actually worked, and as well as discuss some of the side effects of these new treatments. So how common is lung cancer in Singapore? Lung cancer is actually very common. Between 2017 to 2021, we had actually about close to 9,000 new cases of lung cancer diagnosed in Singapore amongst males and females. It is the top 3 most common cancers amongst male and female in Singapore. It ranked number 3 amongst the male, behind prostate as well as colorectal cancer. It also ranked 3rd amongst the females, behind breast cancer as well as colorectal cancer. It is not just common, it is one of the most common cancer deaths amongst Singaporeans. In fact, amongst the male, it is the most common cancer death amongst our males in Singapore. And amongst the females, it is the 3rd most common cancer deaths amongst the females in Singapore, followed closely before by breast cancer and colorectal cancer. And unfortunately, as Dr. Mamta and Professor John Tam has mentioned, majority of our patients are diagnosed in the advanced stage. If you look at the table here, and you can see that up to 75% of our patients are actually diagnosed at stage 3 and stage 4. And there are actually much lesser proportion of patients that are diagnosed in the early stage at stage 1 and stage 2. There is a high-risk group, and as you can see from the age-specific incidence rate here, the risks tend to be much higher as people grow older, because it also takes time for cancer to form, and the high-risk group is actually from the 60 years and above. But not all things are bad in lung cancer. There is actually some good news. And one of the good news is that actually the incidence of lung cancer is falling in Singapore. The death rates from lung cancer is also falling, and we are actually seeing patients who live longer. So as you can see here, this is the curves. The dark curve, it reflects the incidence rates for male and female, and it's actually dropped over the last 3 to 4 decades. And this is all thanks to the National Smoking Control Program that was actually launched by our government since 1986. And if we look at the small little dotty curve that is rising up, that's actually our survival rates. So our survival rates from lung cancer has progressively improved over the last 2 to 3 decades. So let's talk about targeted therapy in lung cancer. What exactly is it? Back in the old days, before discovery of target therapy, of immunotherapy, lung cancer is almost like a death sentence. Advanced lung cancer is associated with very poor prognosis. Even with chemotherapy, majority of our patients live for less than 1 year. And target therapy came about sometime in about 2009. That was a breakthrough for lung cancer. And how it works is that it actually targets the specific pathway of lung cancer. And what's amazing is that this drug can be taken orally, so it's very easy to administer. But it doesn't work for all lung cancer. It only works for patients with sensitizing mutation, meaning things like some of the mutations that you may have heard of include EGFR, ALK, ROS1. And these drugs, they're amazing because they have a higher response rates. Patients live longer compared to if they receive chemotherapy. And they also have less side effects in general. We tend to use them in the stage 4 lung cancer setting, but more and more research have advances, and nowadays we sometimes also use them in the early stage setting after surgery. One of the most common sensitizing mutation is EGFR. Not sure whether you heard of it. It's one of the most common target that we find in lung cancer patients. It is quite prevalent in Asia. About 40% of our East Asians it has this gene mutation, and it's less prevalent in the West at a prevalence rate of about 10 to 15%. And interestingly, it tends to be more common among Asian females who are non-smokers. And the standard treatment is actually EGFR targeted drugs, which are actually oral tablets to target this mutation. And how this drug works is that when you have an EGFR mutation, essentially it's like an on switch. Okay, the moment you have a mutation, the switch is turned on, and thereafter there are many, many downstream pathways that will go haywire, and that will lead to cell proliferation and formation of cancer. And what this oral tablet does is that it blocks the receptor, and the moment it blocks the receptor, it blocks the downstream signaling cascade, and it helps to reduce growth and cause shrinkage of the tumor. I just want to share with you 3 amazing facts about lung cancer target therapies. Number 1 is that it can induce a fast and durable response. So this was a patient who presented with a symptomatic cough for 6 months, and a CT scan showed that there was a left-sided lung mass. She was found to have a positive mutation and was treated with oral tablets that target the mutation, and 3 months later, you see significant shrinkage of the cancer. The second amazing fact is that some of these targeted therapy can actually penetrate our brain, because sometimes lung cancer has a propensity to penetrate the brain, to actually cause brain metastases and spread to the brain. In fact, 10% of our patients upfront have some form of brain metastases. So therefore, we actually need to find treatment that can actually treat cancer in the brain. And actually, these target therapies, some of them can actually penetrate the brain and treat brain metastases. So this was a patient who presented with seizures as well as weakness in her left arm, and she had a significant number of brain metastases, as you can see from the MRI brain here. She was found to have the EGFR mutation. She was treated with the 3rd generation EGFR TKI, which is osimertinib, and after 6 months, there was significant improvement in the brain metastases. And the third amazing fact is that the side effects are generally quite mild and they are tolerable. A lot of patients, they resume normal life. They go back to work. They go back to their usual daily activities. But however, these drugs are also not totally innocuous. They do still carry some side effects. And some of the common side effects that we counsel our patients, for example, on EGFR TKI, is that it can cause pimple-like rash. It can cause diarrhea, but these can usually be supported by anti-diarrhea medications, by creams and moisturizers. It can sometimes also cause liver blood test abnormality, or pyorrhea, which is a bit of inflammation in the nails. And it has a very, very rare chance of sometimes causing this inflammation in the lungs, what we call interstitial lung disease. So this is a rare complication that occurs in less than 5% of the patients, but we always counsel patients that the moment they start taking this medication, in the first 2 to 3 months, if any time they feel more breathless, having cough, increased cough or fever, they need to be admitted, because this complication, although very rare, it can sometimes be life-threatening. So EGFR mutation was just the beginning. More and more, if you can see here, there are many, many targets that we can use that are available today, more and more targetable mutations, and more drugs that are approved for these targets. Example would be things like ALK, MET, ROS1, HER2, and in the last 2 decades, these are all the drugs that have been approved worldwide for these various mutations. So it's really amazing. Another most common mutation is the ALK rearrangement. It is not as common. It is only occurs in about 4% of patients, not as common as EGFR, like 40%. We can also have used target therapies for these patients. There are first generation, second generation, third generation target therapies. And these second and third generation also have very, very good brain penetration that we can use to treat patients who have brain metastases. Just want to share a patient that was treated in NCIS. This was a 55-year-old gentleman. He was actually completely asymptomatic, but he presented with an abnormal chest X-ray with a right lung mass on health screening. As you can see here, the X-ray shows that there was a lobulated lung mass in the right upper lobe. On CT scan, as well as further scans, we diagnosed him with metastatic stage 4 lung cancer. And on mutation testing, we found that he actually has the ALK mutation. So he was started on the third generation ALK inhibitor since November 2015. And there was quite a quick response. Within 6 weeks, the tumor shrank significantly on the CT scan, as you can see here. And even on the scan in February this year, which is close to 8 years on, there's near complete response of his cancer. So different target therapies can have different side effect profile. For this particular drug, it can cause high cholesterol. Okay, and a lot of patients will need to be on cholesterol medications, but it doesn't really cause any harm beyond that. It can also sometimes cause a bit of mood problems, especially in the first part of the treatment, but they're usually mild. And it can also cause mild swelling in the legs and hands, and also mild numbness. But overall, very tolerable drug that people can take for many, many years. There's also a great move towards personalized medicine. I think you have heard of this statement in our NCIS video. Patients can sometimes develop resistance to target therapy. That means target therapy may not work forever. And we are also starting to understand what are some of the resistance mechanisms towards this target therapy. So therefore, it is very important that we continue to study these tumors for patients to undergo repeat biopsies and tumor sequencing, because every patient has a different journey, and every patient's cancer is also very different. So in summary, I think target therapy has dramatically improved the outcomes of lung cancer patients. We see good responses, prolonged survival with our patients on these treatments. It is usually well tolerated with very mild side effects, and molecular testing on what type of cancer, what kind of mutation is of great importance in this era of target therapy. There are many clinical trials underway, and there are many, many new emerging evidence that will emerge in the years to come. Next up, we'll talk about immunotherapy. This is also a new wave of treatment since 2015. I think in the last 8 years, that's been one of the new wonders in lung cancer treatment. So I think we need to attribute and honor these two heroes, is Dr. James Allison as well as Professor Tasuku Honjo. These are the two professors that actually discover immunotherapy to treat cancer, and they received the Nobel Prize in 2018 for their work. And this is how immunotherapy works. I think before you understand immunotherapy, you need to understand the normal immune system. In our normal immune system, okay, our immune cells, like our T cells, when they see cancer cells, they will recognize it and they will kill it. But the scientists then discovered that actually cancer cells are very smart. They start to possess things like this thing called the PD-L1 molecules. Okay, so when you have the PD-L1 molecules, okay, they will bind to the PD-1 receptors of the T cells, and the tumor cells can then go into hiding. So they will not be detected by our immune system. So what this immunotherapy does is actually an intravenous drug, but what it does is that it breaks the connection between PD-1 and PD-L1 ligand. And the moment it breaks the connection, your immune system becomes active again, and then it can recognize the cancer and kill it. To understand immunotherapy, we should also understand the cancer immunity cycle. It is actually a 7-step process where the cancer cells release cancer antigen. It will cause priming and activation of our immune cells, and our immune cells will then be activated, able to recognize the cancer cells and kill the cancer cells. And why we understand this cancer immunity cycle is because that's how we develop drugs. That's how scientists develop drugs to target this cancer immunity cycle. And as you can see here, there are actually many different kinds of immunotherapy that are available. Some will target the step 3, some will target the step 7. But the whole idea is to enhance your immune system to kill the cancer. And we always tell our patients, this drug is amazing because it uses your own immune system to fight the cancer. Let us talk about some of the role of immunotherapy in lung cancer. This was this is Keynote 024. This is a landmark study that was published in 2016. Why I say it's landmark because it confirmed in a large international study that immunotherapy was superior to chemotherapy in the first-line treatment of advanced lung cancer patients, those patients with high PD-L1 expression levels of 50% and above. Immunotherapy in general has less side effects than chemotherapy. Chemotherapy sometimes can cause hair loss, lowers your immunity, nausea, vomiting. It can cause oral ulcers, diarrhea and tiredness. And immunotherapy actually causes very little side effects compared to chemotherapy. It has hardly any of these side effects, or actually even if it has, it's very, very mild. So beyond just single agent immunotherapy, we have moved forward greatly since 2016. Trials have now combined chemotherapy plus immunotherapy together, and we know that this combination is superior to chemotherapy, it is effective, and it can also prolong survival in our patients. Later on, trials have also combined immunotherapy with another immunotherapy to enhance the whole immune response, and this combination has also been shown to be safe, is effective, and it also trumps chemotherapy in advanced lung cancer patients. So this was a case example, a patient of mine, 63-year-old gentleman that was diagnosed with stage 4 lung cancer. We did mutation testing, but unfortunately, he didn't have any targetable mutation, so we couldn't offer him any of the target therapy. But he had quite high PD-L1 expression of 80%. But because he was so symptomatic, he was breathless, he was on oxygen, with a very high tumor load on the left side, we decided to use combination of chemotherapy and immunotherapy. And as you can see, after 2 cycles, there was significant shrinkage in his cancer. He felt a lot better, and even after 4 cycles, the tumor continued to show shrinkage. And thereafter, he was on maintenance immunotherapy and a single agent chemotherapy. It's been over 2 years now. He's still doing well on treatment. He only has very, very mild side effects of skin rash, but otherwise he's traveling around the world and he's doing his daily activities, normal daily activities of living. So here are some of the key milestones in use of immunotherapy in lung cancer. As mentioned, the landmark study was in 2016, and thereafter there was no turning back. There's been lots of trials looking at chemotherapy and immunotherapy combination, or immunotherapy and immunotherapy combination, and more is even moved forward in the sense that initially we used it in stage 4 lung cancer patients, but now we are also using it in stage 3 and early stage lung cancer patients. So as mentioned, immunotherapy is also now used in earlier stages like stage 3 lung cancer after concurrent chemoradiation. We typically give patients with stage 3 lung cancer chemotherapy and radiotherapy. But even with this treatment, a lot of patients relapse. And we are talking about 5-year overall survival of 5 to 15%. That means only 5 to 15% with this treatment will be cured of cancer after 5 years. A lot of them relapse along the way. But in 2018, after an international study was published, we started using immunotherapy for 1 year for this after chemoradiation in this group of patients. And now, as you can see, the survival rates have significantly improved. We are looking at a 5-year survival rate of 42% compared to what we have in the past of 5-year overall survival of 5 to 15%. So to me, this was a major hurdle that we have crossed in stage 3 lung cancer. We're also using it now in early stage lung cancer. There have been studies to show that in early stage lung cancer, after surgery and after chemotherapy, if they have high PD-L1 expression, we can also give them 1 year of immunotherapy, and that has been shown to improve survival. But I also want to emphasize that surgery is still the gold standard of care in early stage resectable lung cancer, and immunotherapy has not replaced it at all in the early stage lung cancer setting. So you ask, is immunotherapy suited for every patient? And the answer is no. Actually, not all patients can receive immunotherapy. You need to discuss this with your doctors. There are some patients that cannot, and who are those? Number 1, those with underlying autoimmune disease, where their immune system is naturally active and already attacking their own body. You can't use immunotherapy for these patients. Those patients who have undergone organ transplant and on lifelong immunosuppressants, where you need their immunity to be on the lowish side, where you're trying to suppress their immunity, these patients are not suited for immune checkpoint inhibitors. Those patients on long-term steroids are also not suitable. So let us talk a little bit about side effects of this class of treatment. Okay, I want to emphasize that it's usually mild. Common side effects are mainly fatigue, nausea, and a bit of skin itch. But sometimes when the immune system becomes very active, it can also attack some of our normal organs and what we call serious organ-related immune adverse events. It's generally rare, occurring in less than 10% of our patients, and the precise mechanism of action is unknown, but it's related to a very heightened immune system that attacks our normal tissue. But nonetheless, if it's detected early, you can reverse it with steroids. And this is what we call the organ-related, immune-related adverse events, where it can literally affect any single organ of our body. Examples will include things like colitis, where it attacks our colon and will result in very profound diarrhea and abdominal pain. Or it can also attack our pituitary gland, causing hormonal imbalance, or attack our skin, causing dermatitis, skin rash, or change in skin color. Sometimes it also attacks some of our hormonal organs, like our thyroid gland, resulting in high thyroid levels or low thyroid levels that need replacement. Or very rarely, it can also attack our heart, and if it does so, it can cause chest pain to our patient, ECG changes, and the only way you can diagnose is actually to biopsy our heart muscle. So in general, we do have a guideline on how to manage these organ-related, immune-related adverse events. But in general, grade 1 is mild. You can actually continue immunotherapy. Grade 2, we'll recommend to hold off the immunotherapy and give the patient steroids. And in grade 3 and grade 4, if it becomes very severe and life-threatening, we actually advise patients to permanently discontinue immunotherapy. And these patients need to be treated with high-dose steroids. In NUH, we have an immune-related toxicity team that comprises of specialists of various organs, and this will allow rapid direct referrals to these consultants who will come and see your patients and initiate treatment if necessary early on. And when we look at our data, we had about 286 patients that had immunotherapy in NUH, and as you can see here, actually less than half had some form of immune-related adverse events. Majority are low-grade, the one in green, okay, and orange, and most commonly will be skin toxicity, hormonal changes, or liver toxicities being most common. But the very serious adverse events, organ-related ones, they are very rare, generally less than 10%. We also studied what are some of the risk factors that will predict for immune-related adverse events among our lung cancer patients, and we found that if you use chemotherapy with immunotherapy together, or those patients who are generally more obese or who carry the EGFR mutation, they had a slight preponderance to developing these immune-related adverse events. So I think in summary, this is a new era of immunotherapy in lung cancer. This is a highly effective therapy. It is more tolerable than chemotherapy. We use it now in stage 4 lung cancer, stage 3 lung cancer after chemoradiation, and also in early stage lung cancer after surgery. But not all patients are suited for immunotherapy. You need to discuss this with your doctors. And immune-related adverse events, they are generally mild, comprising of fatigue, nausea, as well as skin rashes. But the serious organ-related adverse events are rare, less than 10%, and it can typically be reversed by steroids. And I think we have made great progress in the last 2 decades for the treatment of lung cancer. There are many, many clinical trials that are currently underway, including research as well. And I hope we'll continue on this fight against lung cancer and bring better outcomes for our patients and their families. And with that, thank you very much.